So today we are going to have the Neurosciences Forum meeting, monthly meeting, which is co-hosted by IMA, the Pollachi, IMA AMS Pollachi. So I invite all of you for the program. First we will invite Dr. Sendil to give the IMA prayer and the physician's prayer.
No.
Sir, Dr. Vikram sir, our branch secretary will be giving the IMA prayer. Please proceed, sir.
Sir, good evening, everyone. I'll be giving the இந்திய மருத்துவ சங்கத்தின் வேண்டுதல். எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலியிலும் தொல்லை நீங்கி, அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி, பிணிபோக்கும் பெரும்பணி ஆற்றுவோம்.
Thank you, sir. Sir, Dr. Gnanasundar sir is there, sir. Our treasurer, he will be giving the physician prayer.
Sir, good evening, sir. கேக்குதுங்களா செந்தில்?
Yes.
Yes, sir. Proceed, sir.
Yes, sir. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவம் நீயே, உன்னை மண்டியிட்டு வணங்குகிறேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கிறேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பலனை தாரும், பார்வையை தாரும், இதயத்துக்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் எண்ணம், வாடும் மக்கள் படும் பாட்டினை சிறிதளவாவது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசைகளையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகிறேன். Thank you, sir.
Now I invite the Dr. Sendil, who is the president of the IMA Pollachi, to give the welcome address.
Thank you, sir. So today I welcome all our members who have registered for this event and our speakers, Dr. M.Gunasekaran sir, Dr. P.R.Rajkumar sir, and our course directors, Dr. V. Rajesh Babu sir and Dr. Vikram sir, and all our Pollachi branch and other branch members and Neuroscience Forum members. I welcome you all to this program. So this is the second CME which we are doing in association with Neurosciences Forum. So we are planning to do every month, and all our programs will be having 0.5 credit hours. In case you have any problem in payment, you can try tomorrow and you can register. The registration will be open for next 2-3 days. I welcome you all to this program. Over to you, sir.
Good evening, everyone. From the Neurosciences Forum, we are conducting the CMEs regularly every month for past almost 1 year. And in this CME, we are covering the day-to-day very important topics. One neurophysician and one neurosurgeon will be talking. They are the senior experts in our field from our Tamil Nadu, and also from the other states also we are inviting to give a lecture. So this program will be useful for most of the practitioners and the students also. If the students are coming and attending, that will be a very big boost for them. Even the medical student network persons and junior doctors network also can join in this program. So straight away we will have this month program, and today the first speaker is going to be Dr. Gunasekaran, who is going to give a talk on antiseizure medication, my perspective in 35 years. He is a very senior neurophysician. In our Neurosciences Forum meeting, I request all of you to be keenly watching the program, because at the end of both the talks, we will be asking questions, and the person who is giving the targeting the first will be awarded. So I welcome all of you to join the program and actively participate. Dr. Gunasekaran is a retired HOD, Department of Medicine from ESI Hospital, Coimbatore. He did his MBBS from KMCH, Chennai, 1978, and MD General Medicine from Coimbatore Medical College in 1982, and DM Neurology from Madras Medical College, 1990. His achievements are Best Doctor Award for Rotary Club, Tirupur, Best Doctor Award from Collector Tirupur, Best IMA President Award 1920-21 from Tamil Nadu. His experience of 35 years of experience in the neurological field. I welcome you, Dr. Gunasekaran sir, for your lecture on antiseizure medication, your perspective in 35 years. Welcome you, sir.
Thank you very much, Rajesh. Am I audible?
Yes, sir. Audible, sir.
Okay. Very good evening to all of you. So none other than Dr. Rajesh Babu will be the witness for my work at Government Headquarters Hospital in Tirupur, where he was an assistant surgeon with Justice MS General Surgery, where I was working as ARMO and running the epilepsy clinic. So after finishing my DM Neurology in 1990, I was posted in the Headquarters Hospital, Tirupur. It's a small place where I had to start my epilepsy clinic in a government headquarters hospital, which did not have anything at all. In the sense, all I had was my ophthalmoscope, stethoscope, and my chief, I was posted as an assistant surgeon in the medical department, where my chief, Professor Dandabani, was kind enough to allow me to see neuro patients 2 days in a week to start an epilepsy clinic. And the idea of starting an epilepsy clinic in headquarters hospital, probably in a government hospital, headquarters hospital, was the very first in Tirupur. So slowly patients started trickling. Can I have the next slide? So the problem started with a diagnosis of epilepsy. So in nowhere else, no other where clinical medicine is more important than diagnosing epilepsy. As I used to sit in the OP, most of the IMA members from Tirupur used to refer their epileptic patients to my epilepsy clinic, as well as from the government hospital, Tirupur itself. So the range of patients range from all types. It could be a focal patient, it could be a generalized patient, or it could be a patient with MR, or patient operated in Coimbatore Headquarters Hospital for head injury, like that. But you'll have to believe we didn't have even a CT scan in GH Tirupur. So if you take up the newer tools, say like in 2025, you with AI and Chat GPT, we have any number of tools for you to make. Even today, the patient will record an epilepsy event and bring it to you. But whereas in 1990, I did not have much but history taking. History taking was the most important thing, which the students can never go away even today. How did it start? Family history. No, it's a long run. I started the epilepsy clinic with a registry also. So the patients were able to teach you better. Patients were the teachers who told you what is the epilepsy, what type of epilepsy by their history itself. Can I have the next slide? So you take up today most hospitals are having flooded with CT scans, MRIs, EEGs, video EEG, depth electrode, sleep recording, EEG monitoring, and so many things. Definitely EEG may be useful, CT is useful, MRI is useful. But to go back to the history, like what my teachers used to say, even if you are to my revered teacher, late Professor C. Vel Murugendran, or Professor Krishnamurthy Srinivas used to say, even if your EEG machines are thrown into the Bay of Bengal, you should be able to diagnose an epileptic patient and treat them. That was the finest teaching we had from my teachers. I would recall always, because a clinical examination at the interictal period used to be always normal. Interictal EEG may be normal. Even sometimes a 24-hour EEG monitoring or sleep records may be normal, but still EEG, other than all these methods, we know clinical examination and history alone is more important. Associated features, the attendance history, family history, all that were very, very important in making out a diagnosis of EEG. Sorry, making out a diagnosis of epilepsy. In Tripur Headquarters Hospital, I was fortunate to have the support from all the doctors, physicians, pediatricians, OGCians. So many people used to refer their various cases of epilepsy only with clinical diagnosis and to try to treat the patients with the available drugs. Can I have the next slide? So the idea of epilepsy treatment in a resource, repeatedly I used to say this, in a resource-restricted country like ours, epilepsy control becomes very important because he will be the lone earning person. Most often, idiopathic epileptic patients around the age of 14, 15 have been either dropouts from school, even the parents are not carrying them well. Some of them have turned out to be petty criminals and all that. So epilepsy control has to be our aim of treating those patients. So they should be seizure-free. So making them seizure-free, the idea of your drug therapy should be having least or no side effects at all. This is very, very, very important, because side effects with all those, long list is going to come again. It's going to be very difficult for him to continue his occupation, earn his wages, and to live a normal life. So it is very important we are able to make the patient lead a normal social life. Normal social life, to get married like anybody else, to pursue his livelihood like anybody else, bear children. All these things have to be considered in our mind, unlike any other disease, because it's going to be a lifelong treatment. Seizure treatment is going to be lifelong. So these are the aims of this thing. Why do you treat an epileptic patient at all? First thing is, every seizure destroys the neuron. So to prevent destruction of the neurons, to maintain cognition, his daily activities, we have to maintain his epilepsy under control. So that is the main idea. And sudden deaths, sort of, if it is a neurology meeting, all of us will know, sudden onset of death in epileptic patients are well known, to prevent that. And actively, the patient will be able to perform his intelligent work, cognizant work, all those things he should be able to perform. Next slide, please. So just brief, this is very, very brief. This is not a complete classification of the causes of epilepsy. If you just take up, I'll just highlight, first will be a vascular causes. Vascular causes could be a post-stroke patient, post-ischemic stroke patient, or a hemorrhagic stroke, or a subarachnoid, or an aneurysmal rupture. Any of these things can give rise to an epilepsy. Infection, if you take up infection, our side, we used to see very often parasitic infections like cysticercosis or hyoid cyst. These things are common. And tuberculous meningitis can present with the seizures. Also, cerebral malaria is known to present. I remember well, back in 88, we had a patient with severe generalized convulsions with hyperpyrexia. We made a diagnosis of cerebral malaria and we gave him intrathecal chloroquine and he recovered very well. So next is Dr. Rajesh, Babu will know it's a trauma. Trauma to the craniocerebral trauma is a common cause of a seizure. And susceptible patients may need treatment for a post-traumatic seizure for a long time. Next is an autoimmune epilepsy. This is a new upcoming entity. The International League Against Epilepsy has accepted this form of epilepsy way back around 5 years ago as one of the types of epilepsies. This results into autoimmune encephalitis also. Autoimmune antibodies now can be made out like NMDA receptor antibodies. Various types are there. This is another type. Next common type we come across is a metabolic type. Metabolic, the night around 11 o'clock or midnight 2 a.m., the patient will be brought with generalized convulsion for the first episode. So patient will be a diabetic, will be in hypoglycemia. And, porphyria can present with as a metabolic seizure. And hyponatremia is also known to produce metabolic seizures. And uremic encephalopathy patient also may present with generalized convulsions. Next seizure will be the most common idiopathic seizure. See, the idiopathic seizure is which do not belong to any of these things. Usually they have two types of onset, either a childhood onset or an adult onset. Now in this, we have various classifications like myoclonic epilepsy, absences. So many things will fit into idiopathic epilepsy. The next will be neoplasms. Neoplasms, so many brain tumors begin with first episode of seizures. So in a first episode of seizure, with the modern advent of MRIs, we will be able to make out the cause for the seizure. And next common cause will be drugs. Those days when pediatricians used to refer cases, there will be a first episode of seizure. You ask the detailed history, it will be vaccines, especially DPT or DT would have caused a seizure. Or the child would have accidentally consumed some other medications. Or adults can have, penicillin can induce a seizure. Ciprofloxacin can induce a seizure. Next will be toxins. In the toxins, I would like to add alcohol. Alcohol is notorious, especially in industrial town like Tirupur or Coimbatore. It is known most people present with alcoholic either without withdrawal seizure or intoxication and so many. Next will be eclampsia. Eclampsia is a different group of seizures, we'll say pregnancy seizures. And I'm not including pediatric special conditions like West syndrome or Dravet syndrome or febrile plus syndromes. Those come under a separate category. This is a very brief classification. This is not a very highly academic International League Against Epilepsy classification. Can I have the next one? So with these history and these things in background, I was looking at my dispensary, what were the drugs that were available. I had only 4 drugs that were available way back in 1990. The drugs were phenytoin, phenobarbital, sodium alprovate, and carbamazepine. So we'll just take back the oldest anti-epileptic drug is phenobarbital. Sometime I think in 1913 or 1905, this phenobarbital was discovered by Bayer. Bayer, his drug company, he himself started it, for which he was given Nobel Prize. In fact, a patient was given only for schizophrenia. Barbiturates were used only for first schizophrenia. Later, it was like a serendipity, found out that it has a very good seizure control. Interestingly, phenobarbital is being used even today. A very large hospital like CMC Vellore those days used to give only phenobarbital and phenytoin because there were no other drugs that were available. Phenobarbital had a very good seizure control. But unfortunately, especially when you give it for children with febrile convulsions, I have noticed, and many of you would have noticed, hyperactive children. They become paradoxically hyperactive. We don't know how they become. Instead of causing sedation, they went in for hyperactivity. Child will never sit in a class, become very active and all that. But still, in certain conditions, phenobarbital is one of the best drugs. Those days I used to give phenobarbital also. And we had phenytoin sodium. Phenytoin sodium I think Merit Putnam discovered way back in 1938. The drug was used for a long time. But of course, it had a lot of side effects. We have to accept. It had to begin with aplastic anemia, achronocytosis, osteoporosis, and I've seen severe gum hyperplasia. I had to refer them to dentists and ataxias. Other than that, severely fetal pathologies like cleft lip or polydactyly, and VSD, ASD, so many things, because they're called as fetal hydantoin syndrome. But still, as only these drugs were available, I would give either phenytoin, phenobarbital for generalized tonic-clonic seizures. I had about more than 15,000 or so patients who were registered with my epilepsy clinic from 1990 to 2002, till I went to ESI hospital as chief of internal medicine. So the next drug that was available was sodium alprovate. I used to give sodium alprovate for febrile seizures, either with phenobarbital or sodium alprovate alone. Sodium alprovate was a very good drug for myoclonic epilepsy, good drug for generalized seizures. And the difficult things were, it also had a high teratogenicity in the form of neural tube defects and was highly hepatotoxic. Actually, they used to monitor liver functions. But at the time, our lab could do serum bilirubin and sometimes enzyme levels. I used to ask them to go to some available laboratories to have liver enzyme levels, which were quite useful. Very few of the patients had problems with sodium alprovate. And next wonderful drug was carbamazepine. Carbamazepine was used for generalized epilepsy. It's a myoclonic epilepsy. And if you wanted to avoid phenytoin and phenobarbital and sodium alprovate, in especially pregnant women, carbamazepine was one of a very good drug that I used. Probably until I left 2002, these were the only drugs that were available. Now we are fortunate, I think. Our hospital is able to give newer drugs like levetiracetam, though not clobazam or clonazepam. These drugs have been slowly replaced. And the problem is sometimes these drugs are not continuously available. That was causing a very great mishap to the patients who used to have come back with withdrawal seizures. Okay, next slide, please. So this is the same thing I was telling you about. We had problems in dispensing. First thing was patient comes, subsequently you give drugs only for 5 days or 10 days. Beyond that, it could not be given. So I was fortunate from the medical superintendent and the joint director to write to the director of medical services and to get permission to issue anti-epileptic drugs for about a month's time. So the drugs were issued for a month's time. So the patients could travel from, say, distant towns like Udumalpet or Pollachi to collect medicines. So that was something I should be always thankful. And definitely the patients were beneficial out of that. Next slide. So I just tell you a few cases, interesting cases in a short time. A 28-year-old female was admitted with a history of hanging. On her 5th day of admission, she almost regained her consciousness. She was gaining her higher functions. She was improving well. The ward in charge medical officer called me to see her as she developed jerks involving all her 4 limbs with altered sensorium. So concluding this could be hypoxic myoclonus, we started her with sodium alprovate. And as the jerks persisted, we added pyracetam. Sorry about the spelling. Pyracetam. And after a few days, the jerks almost vanished. But I don't remember her cognition. The thing is, we at the time of those days, we didn't have any investigative facilities at Tirupur Government Headquarters Hospital. But still, we could make the patient to go buy pyracetam outside and give. Pyracetam, a nootropic agent, is not approved in either UK or USA. But still, it is sometimes is very useful in myoclonic epilepsy. They are not being controlled. Myoclonic epilepsy, there are various types. Juvenile myoclonic epilepsy. Myoclonic epilepsy can be cerebral, or it can be either in the brainstem, or it can be a spinal myoclonus. So this is a hypoxia-induced myoclonus. Maybe she was susceptible. We don't know about it. Thank you. Next slide, please. So this is another interesting type of patient. A young man was brought to the OP with a very interesting history. The accompanying co-workers in a knitting factory told me that this person would stand still for some time when every time they played a particular movie song. Actually, I remember used to say "Na Na Na It All" from Engavettu movie. It is well known in knitting factories, they used to play loud music to keep the workers agile. When that song was played, he would be in trance state and would recover in few seconds. They had to go and push him, shake him, and to make him all right. Such states occurred often. There is no history of childhood seizures in this patient. So this is a kind of reflex epilepsy, which I did not see, probably, I don't know, in my study time in 88 to 90 in the Institute of Neurology. Only in Tirupur GH, I saw this patient. I started him with carbamazepine, though some claim ethosuximide or sodium valproate is a drug of choice. And in few months' time, he improved very well without any of these symptoms. See, this is what we call it is a reflex epilepsy. This is sometimes even if they think of a music, they can go in for seizures. That triggers epileptic events. There are various types of triggers. Just to list them, it will be a musicogenic epilepsy. It can be a reading epilepsy. It can be television epilepsy. Television epilepsy is well known amidst children. Video game epilepsy. The flickering causes stimulation probably in the occipital lobes, and they develop epilepsy. And some interesting things are there in reflex epilepsy called proxy epilepsy. Something like you could tell him to open like movement or playing a piano or something, some activity like screwdriver activity, he will develop epilepsy. Even some claim there are reflex epilepsies called thinking epilepsies are there. Writing epilepsies are there. So it is very interesting to know about reflex epilepsies. Next slide, please. So you see, visual epilepsies, this is photic epilepsy can be visual, television, video games, or auditory music, the comprehension of the sound. And interestingly, a church bell, a loud church bell can cause epilepsy. I forgot to tell you about hot water epilepsy. I had few cases. The moment they pour hot water, they'll drop from the stool where they're sitting in posture. Immediately what will happen is she'll fall down. After 5 minutes, she'll get up. They were thinking sometimes, unfortunately, women, they thought it's a kind of catamenial event. You know, after menstruation, women used to have hot bath. So they thought it's probably a catamenial event also precipitated a hot water epilepsy. I don't know. I have not got any reference. So hot water epilepsy, also I treated them only with carbamazepine. Most of them recovered very well. Reflex epilepsy is a very interesting, this thing, startle. They used to say, in infants, startle response will be there. Say, for example, after 6 months old baby lying on a couch, to tap the couch fast, it will have a startle, like jerk-like movement. The jerks will slowly disappear at the age of, say, 9 months, 1 year. So abnormal startle persists means the child is not all right. So interestingly, when we talk about these things, we have to consider, is there any organic abnormality in the brain? Can I have the next one? So this is something we should always carry it in the mind. It's a big topic. Women with epilepsy will be a separate topic in neurology forums. An epileptic woman became pregnant, and we tried to switch over from phenytoin to carbamazepine. But due to very many reasons, she continued to have a child with a large cleft lip and a cleft palate. Actually, she was from Tarapuram, Physician referred. We convinced her to take carbamazepine, but somehow I was not able to convince. I think it was about 25 years ago. She said she was comfortable with phenytoin sodium. So she went on to take phenytoin sodium. And unfortunately, she came with a large cleft lip and she was operated, I think, in one of the camps run by our plastic surgeon, Dr. Ravichandran closed it. Fetal hydantoin syndrome is a rare one, very rare one, consisting of VSD, ASD, polydactyly, so many things. And the drug of choice today in a pregnant woman will be number one will be lamotrigine. Many registries have found out many types of these things. Levetiracetam versus lamotrigine. One school says levetiracetam is better. Most of us have found lamotrigine is better than levetiracetam in pregnancy. But we do not, unfortunately, for many reasons, we do not have a large registry of anti-epileptic drugs and their effects. But fortunately, with newer sonograms, fetal sonograms, we were able to detect them much earlier. Can I have the next one? And next, this we talked. Next slide.
Okay.
So this is again about reflex epilepsy. Triggers can be flashing lights, hot water, sounds, reading, calculations. Calculations also. Once you get an answer, you will have slightly dizziness. So we avoid triggers. This will be the best treatment. Next. So this will be kind of algorithm for what will be your this thing. If it is a focal epilepsy, lamotrigine, levetiracetam, lacosamide could be a better choice. Monotherapy alternative could be brivaracetam or topiramate. Add-on will be the same thing. Clobazam is a better add-on. And generalized tonic-clonic fits, valproate, levetiracetam, parampanal. Parampanal is a newer drug, but a few of my patients have used felt it to be very highly sedative. And you can have monotherapy alternate, again, lamotrigine, topiramate, zonosamide. Topiramate and zonosamide are carbonic anhydrase inhibitors. They're supposed to be slightly good. Same, felbamate is not very much available here. Lacosamide we add. For absence, ethosuximide and valproate still the better. But levetiracetam, now we use in absence seizures, we use levetiracetam. Myoclonic seizure, again, valproate is the best. Parampanal will be an add-on. You know, some of the patients do not tolerate parampanal, highly sedative. In West syndrome, we give Acthar gel, prednisolone, and Dravet syndrome, we give valproate and clobazam. And Lennox-Gastaut syndrome, valproate and clobazam are best. And interesting thing about I just would like to mention is those days we used to see, I would say 30, 40 years ago, a lot of mentally retarded children, probably due to hypoxic ischemic encephalopathy. And again, I would say they are due to normal deliveries that were conducted either in the house or in some of the primary health centers due to lack of facilities. So what happened where the child was allowed to suffer from hypoxemia and delivered. So either they go in for minimal cerebral dysfunction, having only cognitive impairment, or they have spastic diplegia or spastic hemiplegia with seizures or simply seizures alone. These things have come down. See, just to quote, Rajesh Babu also may remember, some say 25 years ago in Tirupur headquarters hospital, there were not anesthetists were not available. There were only 3 doctors who were available. One will be on off, one will be on court duty. Only one would have done about 14 anesthesias. So to get an anesthetist as a resident medical officer, I had to get someone from Metropolitan. Imagine a woman is here with a ruptured membrane. The child in distress. And what will happen if we don't perform the cesarean? That will become a birth injury. That will become the APGAR will be grossly lowered. We are fortunate to live in this era to have almost, I think some anesthetists told me there are 20 anesthetists are available in government headquarters hospital and 50 are available in Tirupur town to perform a seizure in no time. And I don't know whether pediatric epileptologists are seeing more number of birth injuries nowadays. We should thank the development. Next slide, please. And this is again the same thing, the mechanism of action. Just to go through it, it's all these drugs act on several these things. Barbiturates, benzodiazepine, vigabatrin, all these, they prolong the chloride channel. Carbamazepine, islicarbamazepine, lamotrigine, oxcarbazine, phenytoin, all are sodium channel blockers. Lacosamide is a slow inactivated state. And we know brivaracetam acts in a very different way. That is synaptic vesicle protein 2A modulator. Again, it comes back to calcium channel blocker, but predominantly it is on the synaptic vesicle blocker. Acetazolamide is an interesting carbonic anhydrase inhibitor. Mostly we use them along with the other anti-epileptics in head injuries. Next, please. This is again the same thing. This is more of academic interest. You can make out where the sodium channel, phenytoin, carbamazepine, oxcarbazine, islicarbazine, lamotrigine act on the voltage-gated sodium channel. Gabapentin and pregabalin, we don't use them as anti-epileptic drugs. Most often we don't use them. Benzodiazepine and barbiturates, you know, they are all GABA enhancers. And perampanel acts at the AMPA receptors. So this is more of an academic this thing. I'm not going deep into this academic this thing. Okay, next one. So just to make my concluding this thing will be, so pathophysiology of epilepsy will be an alteration in a neural transmission. Either an ion or a neurotransmitter. Either there is a blockade or hyperexcitation. This results into hyperexcitability of the neuron and the neuronal network. So there is an alteration in the expression and function. It can be anything. It can be a visual, auditory, motor, or sensory, or more. You know, just to begin with, it can be just visual oscilloscopia, the aura. So that could occur at hyperexcitability of neuron state itself. So next will be alteration in expression and function. So then there is a neuronal loss, axonal dendrite germination. Then he goes in for seizure. So our idea is to prevent at the first level or the second level. So the seizure threshold, once it reaches, seizure episode begins. So our aim of treatment of any of these things will be to block with available drugs at any of these levels. So I think this is a very brief talk on epilepsy. This is not highly academic. And I thank the IMA Tirupur for their supporting me with all their patients. Each patient taught me something or other. Each patient by saying that I have this, I developed this. A patient used to say, a complex partial seizure patient, Manakolappa Valipino, sir. There can't be a better translation than this. Manakolappa Valipino. So how beautifully he has expressed it. So I thank Neurosciences Forum for giving me this opportunity. Thank you very much. Thank you, Rajesh. Thank you, one and all. Can you have this thing? This is classical. I have just taken it randomly. This is classical of 3 per second petimal epilepsy absences. Beautifully it has come. So by giving a apt drug, clobazam could be a apt drug, or sodium alprovate could be a drug of choice. Especially in females, you will avoid sodium alprovate. Clobazam could be a better drug. Thank you very much for patient listening. Next. Thank you.
So it was a nice lecture. So we will have the question answer session and the quiz at the end of the talk by Dr. Rajkumar sir. So Naveen.
So 1 second, sir. Dr. Rajkumar's slide is open.
The second speaker will be Dr. Rajkumar, who is going to give a talk on advances in the neurosurgical management of the malignant glioma. Because this month is a Dr. P.R.Rajkumar is the senior consultant neurosurgeon at Royal Care Super Speciality Hospitals, Coimbatore. His achievements are President of the Tamil Nadu Association of Neurological Surgeons, Organizing Secretary of the Neurotrauma 2017, Secretary in Madurai Neurosurgical Academy since 2017, Secretary in Coimbatore Association of Neurological Surgeons 2017 to 19, President Coimbatore Association of Neurological Surgeons since 2019, Organizing Secretary of Madurai Neuro Academy 2023, 8th Official Conference of Madurai Neurosurgical Academy at Sterling Fern Hills, Ooty, November 3 to 5, 2023. President of Coimbatore Neurological Society since 30/12/2023. Examiner in National Board of Examination in DNB Neurosurgery. Certificate of Academic Excellence by Indian Medical Association, Coimbatore Branch 2023. President-elect 2024-25, Tamil Nadu Association of Neurosurgeons. The publications, he is having an empty number of publications. He often attends the international conferences and also the national conferences. These publications are intraparenchymal temporal lobe abscess caused by group F streptococci. Article October 2010, Indonesian skull-based surgery and initial institutional experience in PSG IMR. Coimbatore article December 2013, Journal of Neuroendoscopic Supplement. Intradural extramedullary spinal cord tumors, a series of 72 cases, article May 2015, Global Spine Journal. Paroxysmal sympathetic hyperactivity in acquired brain injury, a case series, Iran Neurosurgery 2022. Case series of spinal epidural hematomas, a single center experience, Iran Journal, Neurosurgery 2022. Now I welcome Dr. P.R.Rajkumar, the President of Tamil Nadu Association of Neurological Surgeons, to give his lecture. Welcome you, sir.
Good evening to all. Am I audible?
Yes, sir.
Yes, sir.
We'll be sharing the screen. The intracranial tumors incidence is 5 to 10 in 1 lakh population, and glioma incidence is 4 to 6 people in 1 lakh population. When I started my neurosurgery M.Ch in 2000, at that time our teacher used to tell the incidence is 1 to 2 in 1 lakh. So when I did my M.Ch from Madurai, at the time 10-12 lakhs population, so you will be able to see a 12 glioma cases in a year like that. So 1 to 2 in 1 lakh. Now it has increased to 5 to 6 lakhs. So what is the numerous advances has come in the surgical management and other supportive treatments like radiotherapy and chemotherapy. But whatever it has come in case of malignant glioma, which is the one thing is not possible, that is the tumor clearance. Usually, if you have a tumor in the stomach or intestine, whatever it is, you will give a clearance of few centimeters of that structure, and that you can have near normal function. But in brain, it's not possible, because in a malignant tumor, you will be removing the tumor, which you see through the microscope or whatever the other method, using the tumor fluorescence, whatever it is. But the cells are spread into the normal brain parenchyma, even though for post-operative CT is 100% no residual tumor, there is no guarantee that it will not recur. So that's why the grade 3 and grade 4 tumors are always, even after the resection, the difficulty, it is very difficult to get 100% resection, but even though it is there, the follow-up treatment in the form of radiotherapy and chemotherapy is always there. So what are the malignant gliomas? Grade 3 and grade 4 are called as malignant gliomas. For example, we have glioblastoma multiforme, anaplastic astrocytoma, anaplastic oligodendroglioma, anaplastic oligostocytoma, and etc. So what is the neurosurgeon's role in glioma? More you remove, it's better, but not at the cost of neurological morbidity. That is called the safe maximal resection. So the aim of neurosurgeon in malignant glioma treatment is safe maximal resection. So you should not create a new neurological deficit. That is the aim. You have various types of resection. Gross total resection, there is no residual tumor in postoperative MRI T1 contrast. Near total is less than 5% of the tumor volume in the postoperative MRI. Subtotal is 5 to 10% of the residual tumor. Partial resection means more than 10% of the residual tumor. Usually this tumor volume is calculated by the measuring the axial, sagittal and coronal preoperative, postoperative MRI scan and dividing that the values by two and comparing the preoperative volume and postoperative volume, we will come out the how much residual volume is left. So what are the pre-op investigations you will do when you suspect a patient with brain tumor who comes with the symptoms of headache, seizure, weakness, and ICP type of headache and all the visual loss, everything. So usually you do CT brain plane in contrast to find out some lesion is there. To get more clarity about the lesion, you do with the MRI brain plane and contrast. If you see a tumor in the brain, which is intraparenchymal, irregular, varied enhanced in contrast, there is some necrosis that like report is there, and you have to go for spectroscopy to find out whether there is any choline peak is there. The choline peak is high, then it will be a aggressive glioma. So these are for identification. Other investigations for some therapeutic significance. So you do fiber tractography. See, if you see some tumor near motor cortex or sensory cortex or language area or speech area, whatever it is there, or occipital cortex. So you do what are the fibers are there nearby. So most of the tumors are in frontal and parietal region, then temporal, least in the occipital, the gliomas usually. So the fiber tractography will help to which way you can go inside and safeguard the tracts and remove the tumor. Then functional MRI. Functional MRI gives, it is nowadays the functional MRI is done, this intraoperative neuro monitoring is there. So the functional MRI which is done before the surgery is not very much popular now. The functional MRI, you will find out the patient will be moving the hand, the hand area will get the more blood flow. When patient writes, the writing part will get more. Like that, you motor area, sense area, and language area, you can map in the MRI shoot before surgery. That is MRI functional MRI. Then MR angiogram, and you will do the how the vascularity is there, which vessel is supplying the tumor. If it's a highly aggressive tumor, if you see a very large vessel supplying, maybe not one single vessel, multiple vessels, if you are able to embolize the vessel preoperatively, then DSA and embolization can be done. It is usually done in the western part where if they see a very aggressive tumor, they embolize and they take the tumor within 24 to 48 hours. Sometimes if you have a doubt of some metastasis or tumor originates from outside the brain and metastasis to the brain, then you will do the whole body PET to find out. So what are the intraoperative technologies available at present for doing the surgery? You have neuro microscope, the various types from higher end to the simplest one. And you have neuro drill for craniotomy, CUSA for removing the brain tumor. Now we have the new surgical diode laser, neurosurgical separate laser is there. With that, you can make a cortical incision. Bipolar cautery is routinely used. You have intraoperative neuro monitoring where you can monitor, you can map the motor area, sensory area after doing craniotomy. And you have neuro navigation, the navigation machine, which is uses the stereotactic principle. We do registration and we locate the tumor before putting the incision, before doing the craniotomy, so that you can plan the surgery in a minimally invasive manner. And intraoperative ultrasound CT MRI. See, these are the other gadgets available intraoperatively, but it's not available in all centers. Intraoperative ultrasound is out of the three that can be feasible. With the training, you can, after opening the dura, you can put the ultrasound probe and identify the tumor, and you can plan your surgery. And the most important thing is neuroanesthesia. So while doing intraoperative neuro monitoring, the patient should not be given muscle relaxants, or it should be in total intravenous anesthesia. So patient will be made awake during examining the important functions. So post-operatively, you do a histopathology to do the grade and type of the glioma. Main important is molecular study, and the methylguanine methyltransferase IDH1 and 2 mutation, 1P and 19Q co-deletion, EGR of gene mutation, TED mutation. These are all done for all malignant and low-grade gliomas. So when MGMT promoter IDH1 and 2 mutation is there, then it will have good response to radiation and chemotherapy. 1P and 19Q co-deletion is there, then it is oligodendroglioma. So if MGMT positive, IDH positive, and TET positive is called triple positive, that will be a very good response to radiation. So all malignant gliomas has to be radiated, and patient has to be on chemotherapy. So follow-up MRI usually done to find out the residual tumor volume and to plan further radiotherapy. See, what are the advances there? Fluorescence guided resection. So the tumor will fluorescent under microscope. You will be able to remove the tumor. Navigation guided resection, laser resection, IONM guided resection. These intra USG CT MRI, they will give the real-time intraoperative view of the tumor status while doing surgery. So CT and MRI, you need a radiologist and other problems that we can see the later. We'll go one by one first. This is neurosurgical laser, the surgical iodide laser. You can make the cortical incision. At the same time, it coagulates. It has emits the heat such that it will not damage the underlying structure. This has come in resection. Even if the QSA, it is very hard and difficult. This laser can be used nowadays. This is a video showing an example of making an incision in the cortex. You can see at the time it cuts and coagulates. So a lot of slides are there. We will move fast. Next is neuronavigation. So as I told, it's a stereotactic principle is used to localize the tumor after anesthesia, to identify where you have to put the incision, where you are going to open the bone, to craniotomy, and where you are going to open the dura. And you can measure how much depth from the surface it is the tumor. That for that the navigation is used. See, what are the restrictions there? Time consuming, you have to register the calculation and everything you do. The patient should not move intraoperatively. If the patient moves, then you have to re-register. When after opening the dura, there will be a CSF has come out, then there will be some brain shift and tissue deformation after doing some resection. At that time, the navigation will not be correct. For that only, now we have the intraoperative ultrasound, CT and MRI, everything. These are a few examples to show that there is a tumor here in the first picture, and navigation is used. So, and the picture down shows the while resection, the photography. So this is again another one. This is the principle which is used. We can see from the skin up to the tumor, and we can see the anterior border, posterior border, medial border, how to go, through which cortex you have to go, that all can be decided. So intraoperative ultrasound, you can see the first picture where the tumor is there. You can see the ultrasound view, and it is resected. After that, you can see the tumor is not seen in the ultrasound. It's a real-time imaging. The brain has some viscoelastic features, so that its structural architecture is seen very well through the ultrasound. It can be repeated several times. The disadvantage of navigation is overcome here. The brain shift can be, you will not alter the ultrasound picture. It's cost effective than CT and MRI, which is intraoperatively used. It's an easy to use technique. After learning, curve is also very short duration. So intraoperative CT and MRI very costly. MRI compatible instruments when you are having, I think central institutes, I'd say All India Institute, NIMS, they are all having. But whether they have used initially, now whether they are using the intraoperative MRI or not, we don't know. When it was launched around a decade back, it was new. Then the cases were done in intraoperative MRI suit, that's called brain suit. So what the MRI compatible? All instruments should be MRI compatible. Radiologist or radiology technician should be there while doing surgery. Maybe compatible if they have, if you are doing a high volume glioma cases. Now coming to the sodium fluorescein gate resection. The sodium fluorescein was first introduced by George Moore. He used it in pathological tissues and he seen under microscope the fluorescence. Then he told that it can be used in tumors in the brain also. The sodium fluorescein is a simple dye used in ophthalmology, which is approved for retinal angiography. Now the European medical agency has approved this fluorescence for using in malignant brain tumor. And the US FDA approval is there for sodium fluorescein for using that cerebrovascular study. Intraoperatively, you inject sodium fluorescein and take under microscope, you can visualize the intracranial vasculature. That's like middle cerebral arteries branches, anterocerebral artery branches like that. And if you take a tumor which is stained with sodium fluorescein, it can be used. That's Carl Zeiss has introduced this conveyor laser endomicroscopy. You take the tumor, there is the endomicroscopy machine is there. You can see the tumor. You can find out somewhat grade, and you can give the intraoperatively radiotherapy. So all three solutions are possible in a single place. So it's a sodium salt of fluorescein. It's organic dye. At 560 nanometer filter, the tumor will glow yellow. So this fluorophore should be tumor specific. It should be more in the tumor than the normal brain. It should have a very good fluorescence. It should be biocompatible, non-toxic, and it should be cost efficient. These criteria are mostly met in sodium fluorescein. Another one dye is there. That is aminolevulinic acid, which is used for low grade and high grade tumors, but that is a little costly. This is 200 rupees. That is, I think, around 80,000 to 1 lakh rupees. That is the difference. But fluorescein has very good side effects, no adverse effects, executed rapidly. With the filter, you can do surgery and you can cauterize. But aminolevulinic acid is costly, limited availability. But after using this, patient should not be exposed to light or sunlight, phototoxic, it is phototoxic. So patient has to be shielded from light for first 24 hours. So for sodium fluorescein, only malignant high-grade tumors has to be selected appropriately. And the fluorescein, the dose of 3 to 5 milligram per kg, 35-45 minutes before craniotomy. If you use, then fluorescence will be there for up to 4 hours. So how to find out the tumor which are high grade? Heterogeneous enhancement in MRI plain and contrast. There is necrosis, edema, hemorrhages. Spectroscopy shows, as I mentioned before, increased choline level, peak. So this is a 56-year-old male. You can see in the left temporal, there is a large lesion around 4 to 4.5 centimeter. You will see all the what I told before, that irregular enhancement, edema is there, and necrosis is there. And for this, we use the fluorescein. This is the normal light, first picture. Second picture, under the yellow filter, you can see the tumor is glowing very well. So you can see the vessels, everything it can be seen in sodium fluorescein. So this is after making the incision in the normal light under fluorescent light. You can see the tumor is removed with CUSA. The second picture is tumor is removed totally before hemostasis. This is after hemostasis. And this is the pre-op MRI, this is the post-op MRI. I think there is a small residue seen in the posterior aspect of the cavity. Maybe it may be a residual tumor. So what is the difference between sodium fluorescein? We use sodium fluorescein because it is cheap and it has no side effects. But sodium fluorescein accumulates only not in the tumor cells. It's in the disrupted blood-brain barrier. But 5-ALA, it's intrinsic. The protoporphyrin 9 is accumulated inside the tumor cells. When you inject 5-ALA, that will fluorescent in pink color. So that is the advantage. But that has been approved by US FDA, but this is approved by only European Medical Academy. So these are other things we have done already 65 cases, and we have various levels of resection. Our resection, very good resection is around, you can see 96% in the second. Every time you cannot reach more than 90% because the tumor is near eloquent area. So now very ultra low dose fluorescein can be used 2 milligram or 1 milligram. This is the World Neurology Journal. There's a paper regarding that. And again, it has the same as effective as what you give 5 mg. And this is another literature review where you can use the combined fluorescein, sodium, ALA, and how is the resection, gross total resection is. So overall survival rate, progress-free survival rate. When you use intraoperative MRI, when you see the tumor resection intraoperatively, and if you see a residual tumor, you can remove. That advantage is there when you have intraoperative MRI. When you do use dye with intraoperative MRI, the resection rate is very good. When there is a recurrent tumor or residual tumor is there, later going for surgery, that can also be fluorescent dyes can be used. There is a latest paper which shows that fluorescent dye is now some tumor cells are taking uptake intake. So next we will go to the intraoperative cortical mapping, which is usually used when the tumor is in the motor sensory language areas. So these are the investigations you have to do. You have to measure the preoperative tumor volume and you have to do the fiber tractography. This is a fiber tractography with I think 7 Tesla, I think so. So main important thing is when it is a motor cortex tumor, you have to know to corticospinal tract and superior longitudinal fasciculus. The green and pink is the corticospinal tract, and in the last picture you can see the yellow is the superior longitudinal fasciculus, which is mainly for language. So language is mixed thing. It's a speech, hearing, everything combined. So these are the 2 tracts when you have to see in fiber tractography and its relation to the tumor. For example, I am showing this is a tumor in the motor cortex where the corticospinal tract in first picture is displaced posteriorly. Sometimes it may be split in between. If it is displaced posteriorly, you come through the precentral sulcus. If it is divided split, then you have to come through where the tumor directly, where the tract is not there, through that you have to enter the tumor. When it is anteriorly displaced, you have to come through the posterior to the sensory cortex. So this is a nomenclature motor cortex. You can see zone 1, zone 2, zone 3. Zone 1 is in the interhemispheric fissure medial cortex, that is the medial motor cortex where you have the foot, hip and trunk. And zone 2 is arm and hand, and the zone 3 is face, tongue and larynx. So anesthesia positioning, you will put the electrodes after anesthesia and we stimulate and see the various MEPs, somatosensory potential and everything. And after doing craniotomy, you will map where the motor cortex, everything is there. I will show you the example. There is monopolar stimulation, bipolar stimulation, that all can be used. It's entirely a neurophysiology thing. And you have another equipment which is called the subcortical probe, which when you are close to the motor cortex, the sound which is continuously there, high pitched, will turn into low pitch. So the low pitch is when 5 milliampere current is passed. If you hear high pitch to low pitch, then corticospinal tract is 5 millimeter from the your tip of the suction probe. At the time, you have to stop the surgery to safeguard injury to the corticospinal tract. So benefits of mapping, intraoperative mapping is preservation of function, accurate surgical planning. You can reduce the complications. What are the complications of as such of intraoperative cortical mapping? So we are keeping in the lighter plane of anesthesia. Patient can develop seizure intraoperatively because in the lighter plane of anesthesia, hypertension can come, brain swelling and edema come. So because of the brain swelling and edema, post-operative new deficits can come. Because of stimulation during the cortical mapping, visual, see motor and sensory potential, patient may experience pain. Sometimes if you have the language cortex is not on the left side, if it is a right side, you will find difficulty in mapping. Hypoxia and nausea, vomiting, these are the other complications. This is a 43-year-old male with seizures and weakness of the right limb, difficulty in speech for a few days. On examination, he had dysphagia, hemiparesis, and drowsy. He has other associated problem also, myelodysplasia, aplastic anemia. He was treated for tuberculosis 1 year back, incomplete treatment. He has diabetes mellitus and systemic hypertension. You can see the tumor. You can see this is a high-grade tumor. This is the contrast study. This is the spectroscopy. You can see the choline, which is seen in the center. This is the choline spike is there. So reported as highly aggressive glioma. Lot of edema there. So this is the post-operative picture. Because of the edema, we have to remove the bone flap. This is the MRI taken on the 12th day. Through this, the trajectory is seen, and you can see in the last two pictures, small amount of residual tumor is there. You can see the electrode is placed to find out which is the central sulcus. So here the central sulcus between second and third. You can see the first two waves, that the downward amplitude, the third wave becomes upward amplitude. That phase reversal, we call it as the phase reversal occurs at the central sulcus. So the in between second and third electrode, the central sulcus is there. Then third and four is the precentral gyrus, that is the motor cortex. 1 and 2 is the sensory. So this is again the same to say that you can see the downward thing and the phase reversal, then it becomes upward. So between 2 and 3 is there. This is a small video of that surgery. Under microscope, the tumor has been removed. You can see the tumor. It's very hard, firm, not hard, firm. The tumor forceps, we are taking a bit for biopsy. This is again this is SSEP. You have put the incision site is at the third and fourth electrode, where we don't get any SSEP waves. The safe place cortex, the gyrus is opened to reach the tumor. See, this fiber tractography is used for all other places also. There is high-grade glioma in thalamus, some meningiomas, supratentorial ependymomas, and in the fourth ventricle tumor, which are adherent to the midbrain, to find out the tracts. So, in conclusion, the extent of resection, maximum safe resection, preserving the functional areas in brain are important in the neurosurgical management of gliomas. Overall survival rate, progression-free survival rate, and quality of life during the survival period is more important in the management of gliomas. Quality of standard of neurosurgical surgical care can be achieved through the neurosurgical technique and various technologies available. And there is no need to have all. It is very difficult for every center to have intraoperative MRI, CT, or ultrasound. At least we should have some technology to localize the tumor and safely remove the tumor. And during surgery, you should safeguard the eloquent areas. Thank you.
Thank you, Dr. Rajkumar sir. It was a very nice, excellent lecture of discussion about. It was very much useful to all the practitioners, I think, so that they will be knowing which are all the cases, what are to be done. You have talked up to the latest developments, so it is very nice. Hello.
Yeah, I'm here.
Yes. Come on, you can tell the word of thanks.
It was a great topics, both of Dr. Gunasekaran sir and Dr. Rajkumar sir. For the postgraduates and general practitioners, this will give you a crisp concept about convulsions and the management of gliomas. I think the participation of people were also quite good. I think it reached nearly about 200 participations. Hope the information what both the speakers have shared with their great experience and very practical day-to-day useful informations will help them to practice and to improve their knowledge. Thanks for taking so much of pains and explaining, giving the very simple and understandable concepts about both the topics. Thank you, sir. Thank you. Thanks a lot.
Thank you.
Thank you, Dr.
Thank you.
Rajkumar and Dr. Gunasekaran sir. It was a very nice discussion.
Thank you,
And
Rajesh,
it
for
was
the
very much informative for all the practitioners around. It almost touched 200 people now.
thanks for
Thank
the
you.
opportunity,
Thank you.
Rajesh. Thank you very much.
Thank you, sir.
Bye.
Thank you.
Good night. Good night.
Good night.
Good night.